So in critical care, the most common research that we read about is research about therapy. And this is a guide to critically appraise and randomized controlled trial dealing with a therapy. Well, this has to start with a disclaimer. I'm not an expert, and the things that I'm going to discuss in this session are things that I've learned during my training as an RCU registrar and an RCU consultant. If you do find anything that you know or do not believe to be true, please get in touch with me and we can discuss and learn together.
Now, before we go any further, let's just talk about what is a randomized controlled trial. So the schematic diagram represents the basic structure of a randomized controlled trial. It consists of a sample of patients which are taken from a target population in which the study is intended. They are randomly divided into two groups, treatment group and control group. Frequently, the treatment group receives the intervention and the control group either receives the usual care or receives a placebo. And this placebo looks, feels, tastes identical to the intervention. After a variable time, the two groups are followed up for an outcome which has been pre-decided, and based on the incidence of outcome in the treatment group or control group, there is a comparison to determine whether the treatment group did better or worse or the same as control group. Now, to understand that with an example, let's imagine that you want to investigate whether usual care, which is ceftriaxone azithromycin, is same, better, or worse than your intervention of tazocin plus azithromycin for patients admitted to RCU and mechanically ventilated for community-acquired pneumonia. Now, instead of looking at every patient who comes to RCU with community-acquired pneumonia, you decide to take a sample of that. So you define your inclusion criteria. And on the basis of that, you decide to include certain patients of this target population into your study. So your study sample is patients admitted to RCU with community-acquired pneumonia requiring mechanical ventilation. You randomly divide the sample that you've taken into a treatment group and a control group. The treatment group receives the intervention, which in this case is tazocin plus azithromycin, whereas the control group receives the usual care, which is ceftriaxone plus azithromycin. After a variable period of follow-up, and this follow-up would depend, sometimes it could be RCU stay, hospital stay, it could be 3 months, 6 months, or whatever, you determine the incidence of outcome. And the outcome is something that you've decided as well. So this outcome could be mortality, or ventilator-free days, or resolution of the pneumonia on a chest X-ray, for example, or whatever. So you determine the outcome after a fixed period of follow-up, and then you decide whether your treatment group did better or worse or the same as the control group. Now, whatever result you get at the end of your randomized control trial, the possibilities are that one, you have discovered the truth. So congratulations, you have found out whatever was there to be found out. But there is also a possibility that what you may have found out is not the truth. Now, in absolute terms, nobody knows what the truth is, and that's why we do the study to find out the truth. But it is possible that in the pursuit of truth, that you get sidetracked by something like a random error, systematic error, or a confounder. And these three are the alternative explanation as to why you reach the current conclusion that you reach rather than discovering the truth. And we are going to look at these in a little bit more detail in the coming slides.
So a random error is one which arises just by chance and can produce results which are different from the truth. To just give a different example to the one that we have discussed in the previous slide, let's talk about a coin toss. Now we know that a perfectly balanced coin, if it is tossed even number of times, it should produce equal number of heads as opposed to number of tails. Let's say that we just toss it 2 times. There is a probability that we could get 1 head and 1 tail in either order, but there is also a probability that we could get 2 heads or 2 tails. So if we get 2 heads or 2 tails, which is a 50% probability, we would be different from the truth, but that is in all likelihood happen by chance if the coin is perfectly balanced. On the other hand, you may have an imbalanced coin, so there is an inherent problem with the way we are conducting our study, in a way that it gives predominantly head when you toss it. This is an example of a systematic error. It is not random, it has not occurred by chance. If we were to toss these coins, we know that we are going to get more heads than tails because the coin is inherently unbalanced. So the error that arises by chance is called a random error or chance. The error which arises due to some methodological problem is called a systematic error. And this systematic error may be due to the conduct of the trial or maybe due to the design of the trial. Now, having identified that random error or chance or systematic error, which is also called bias, has a potential to take us away, or our conclusion to take away from what the actual truth is, the next obvious question is, well, how you minimize them. So random error or chance can be minimized by increasing your sample size. So say, for example, if you were to take the example of the coin toss again, if you were to toss the coin 10 times, it is more likely that you would get an even answer of heads versus tails, as opposed to if you were to just tossing the coin twice. There is still a possibility, though, in 10 coin tosses that you get 6 heads or 6 tails. But if you increase that to 50, say, for example, or 100 or 1,000, it is more likely that your answer would approach 50%, which we know the truth to be. Unfortunately, systematic error is not amenable to an increase in sample size, and for that we need a robust methodology. So how do we assess whether the trial paper that we are reading has got a robust methodology which minimizes systematic error or bias? Well, there are certain criteria that we use to analyze the study, and if the study stands true on most of the criteria, then we know that authors have made all attempts possible to decrease the risk of systematic error or bias, and that the result of the study are truer or closer to the truth. Now, this brings us to the set of criteria that we use to study the potential for minimizing bias in a study, and these are tabulated in here in this slide, with the title saying, "Are the results of this study valid?" And the reason we've used the word valid is that if these criteria are fulfilled, then we say that the study has high internal validity. So internal validity of a study refers to the attempts by the author to minimize systematic error or bias. A study with high internal validity is likely to give true results. However, if the study is biased, then we cannot trust the results of the trial because the study has poor internal validity. We are going to study these criteria one by one with examples. So the first criteria is, why was the assignment of patients to treatment groups randomized? Now, this brings us to the question of randomization. So now the question arises, what is randomization? Why do we randomize? And how do we do it? Now, getting to first the question of what is randomization? Well, randomization is a process that ensures that any patient entering the trial has got equal probability of being assigned the control group or intervention group. So that is randomization. Now, why do we randomize? We do randomize because we want to make sure that the two groups are balanced, and that apart from the intervention that we are doing, they are similar in all other respects. And the best way to ensure that is by doing randomization. So randomization ensures that the two groups are balanced and that any confounders are equally distributed between the two groups. Now we've introduced another term called confounder. So what is a confounder? A confounder is another factor which is associated with an outcome, which may be unequally distributed between the two groups, which would cause a bias. Now that sounds complicated, so let's just deal with an example, and that might be easier. So let's say that you read a trial about asbestos exposure and lung cancer. Let's say that, and I know that it's not ethically feasible, but let's just say that there is a randomized controlled trial of 50 patients in an intervention group, which involves their exposure to asbestos, and 50 patients the control group, who are not exposed to asbestos, and you calculate the incidence of lung cancer in them after 5 years of the trial. Now you find that the asbestos group has higher incidence of lung cancer. So the authors conclude that asbestos is associated with lung cancer, and hence it's an etiological factor in causation of lung cancer. But then it is noticed that asbestos group had more smokers as compared to the control group. And we know that smoking is independently associated with incidence of lung cancer. Now that creates a bias. Is the increased incidence in asbestos group, is that because of smoking, or is that really the effect of asbestos? So now we have got a factor, namely smoking, which is independently associated with the outcome, namely lung cancer, but is unequally distributed between the two groups, namely the asbestos group and control group. So such a factor which has independent association with the outcome and is unequally distributed between the two groups is called a confounder. And there are only two ways in which you could deal with the confounders. Either you match the two groups, in which case it would cease to be a randomized controlled trial, or you rely on the process of randomization to make sure that all smokers who enter the trial are randomly but equally distributed between the two groups. And that would be one way that you could actually judge whether the randomization has been appropriate or not. And randomization would not only make sure that known factors like smoking in this case are equally distributed, but any unknown factors, and that might be a genetic factor or an environmental factor, which may be associated with asbestos, which is yet to be discovered, is equally distributed between the two groups. So once you do a perfectly balanced randomized control trial, it makes sure that that any confounder which are known or which are unknown are equally distributed between the two groups. So that's a reason as to why we randomize and what is randomization. The next question is, how do we randomize? So randomization can be done through various ways. The most common way that it is done these days is by centrally generated computer numbers. So there is a randomization center for most big trials, especially if it's a multi-center trial, and you call up that number, and the computer generates a random number, and the patient is allotted to the particular group, and only the computer knows whether that's the control group or the intervention group. It can also be done much cheaply and at a local level with opaque sealed envelopes, in which you have a sequence which is protected with an opaque envelope, and that has a sequence of dividing patients between, or subsequent patients between, control group or the intervention group. There are some other ways which are not considered satisfactory for randomization, and that includes patient's medical record number, date of birth, day of the week, day of the month, so on and so forth. And the reason they are considered inadequate is because though the patient would not have any choice on which group the patient goes to, the clinician would be able to predict as to which group the patient is going to go to, and that would introduce a bias. On surface, it appears that it's a pretty easy thing to pick up, and why would you ever have a trial in which you would have a randomization where the clinician can discover the code, but it frequently happens. So randomization to make sure the patients go into two groups without have equal probability of going into two groups is one thing, but concealing the allocation whereby nobody knows which group is the patient going to go into next is called allocation concealment. So allocation concealment is concealment of the allocation sequence of randomization. So you cannot predict as to what would be, what group would the next patient go to, though they may be centrally randomized. When we discuss it in the next slide, things will become much more clearer. So just to focus on that randomization, inadequate versus adequate randomization, these are two sort of landmark critical care trials looking at effect of hypothermia after cardiac arrest. If you look at just the section on randomization has been copied and pasted from the article. If you look at the top section, it says eligible patients were randomly assigned to hypothermia, normothermia according to the day of the month, with patient assigned to hypothermia on odd number days. Now, In a way, this is still randomization because the patients are randomly going into hypothermia or normothermia group. But there is no allocation concealment. You could predict which patient, the patient on a particular day is going to go into which group. And if the clinician has a feeling that the patient is not going to do well, and the clinician has a bias towards hypothermia, then they may not randomize this patient to the trial at all. So there is no allocation concealment. It's an open randomization, and open randomization is a source of bias. So this study would be perhaps called quasi-randomized trial rather than a true randomized controlled trial. If you look at the next section, the hypothermia after cardiac arrest study, treatment assignments were randomly generated by computer in blocks of 10 with stratification according to the center. Now I'll come to what does stratification mean, but the treatment assignments here were generated by a computer, so nobody had any idea as to which group the patient is going to be going into, and presumably the allocation of the next patient to whatever group was concealed as well. Now, dealing with stratification, stratification is a way in which people, clinical trialists, can make sure that the groups that are generated after randomization are balanced by a particular characteristic. So if you were to look at this trial and this example, which says computer-generated blocks of 10 with stratification according to the center, likely it means center being a tertiary center, tertiary hospital versus a non-tertiary hospital. So the way the computer would generate the numbers is in a block of 10, so 10 patients at a time, making sure that these blocks of 10 have equal distribution between a university hospital and, say, for example, another general hospital. That would make sure that in the end, the group are balanced with regards to the center, and the center does not become a confounder. So what you do not want, or what the trialists do not want, is that hypothermia group, more patient in hypothermia group may have been treated in the university hospital, and less patient in hypothermia group may have been treated in the general hospital. And if that were to happen, a criticism of the trial would be if the normothermia group did poorly, would be that, oh well, the normothermia group has done poorly because most of them were looked after in a center which was not well equipped to deal with this problem, and the only reason that the hypothermia group has done better is that more patients in that group went to a university hospital. So to avoid that sort of a thing happening, it is made sure by stratification that patients get equally distributed in the two groups between the tertiary center or a secondary center. And this is another example of stratified randomization. So these are some of the landmarks trial in critical care. One is the nice sugar trial, which had 180 milligrams or 10 millimoles per liter or less sugar control versus I think tight sugar control. And there the randomization was stratified according to type of admission, operative versus non-operative, and region. It was an Australasian plus Canadian trial. So the idea was to make sure that at the end of the randomization, that there would be equal patients who are medical in the two groups, and surgical patients are equally distributed within the two groups. At the same time, it would be made sure that the same number of patients from Australia and New Zealand are there in both the groups, and Canada as well. And that just makes sure that the type of patient does not become a confounder, as in there may not be more medical patient or surgical patient in one of the other groups, or that geographical location does not become a confounder, as in more patient in Australia and New Zealand group go to one patient where the care may be quite different, not necessarily good or bad, but different from say, for example, the Canadian management. And this is, say, for example, in the trial where patients were, this is I think 6S trial, where which was a trial looking at patients with septic shock, and there the patients were stratified according to active hematological malignancy, university versus non-university hospital, because these were the characteristics that were judged to have a potential to influence the outcome. So in other words, these were judged to be the confounders, and the authors made sure that the patients were randomized in such a way that these characteristics were equally distributed between the two groups. Now, some people do consider this as a less satisfactory way of randomizing, because some people believe that you could actually predict which group the next patient is going to go into. But this is considered a perfectly acceptable way of randomization, and it makes sure that the confounders or potential confounders are equally distributed between the two groups. Another type of randomization is called cluster randomization. And a cluster randomization means that rather than randomizing individual patients, you randomize the whole unit for a particular intervention. And the reason for that is that the giving intervention to one patient has a potential to contaminate the next patient and could affect their exposure. Just to give an example, one of the two studies, let's look at the first one first. It was a study of selective digestive decontamination, which is a therapy which is given to control endogenous bacteria with an intention of decreasing nosocomial infections. And the way the therapy is administered is that a local paste of antibiotics is applied to the oropharyngeal mucosa, and an intravenous antibiotic may be given for endogenous bacteria of the gut. Now, if this therapy were to be administered for individual patients, there is a possibility that the adjoining patient might contaminate the patient who's getting the intervention. So, say for example, you might put oropharyngeal antibiotics and give intravenous antibiotics to a particular patient in order to decrease the incidence of nosocomial pneumonia, but the patient may get a cross infection from the patient next door, and that might dilute the intervention. So for such interventions, usually the whole unit is randomized, and this is called randomization in a cluster or cluster randomization. So the particular trial on your screens at the moment is an example of cluster randomized trial. And the other cluster randomized trial that we sort of know well in Australia was a cluster randomized trial of Med-System, where the hospitals were randomized to go to Med-System or continue to follow the existing system of rapid responses or cardiac arrest calls. And again, it was not possible to randomize a ward patient to receive a rapid response call or not, because once the staff get used to calling rapid response team, they would call whether there is a med system or not. So that had a potential to cause contamination and make it difficult to study the intervention. So the whole hospitals were randomized to either receive a med system or continue with the usual system that they have for sick patients on the wards. The next criteria that you judge a randomized controlled trial is whether the patient, health workers, or study personnel were blind to the treatment. As is obvious by the name, that the patient, the health workers, or the study personnel should not know which group the patient is in and what intervention they are receiving, as in the treatment or the control group. And that can sometimes be easy, but can sometimes be tricky or impossible. And the examples include fluid trials. So say, for example, you want to test whether normal saline or Hartmann's is a better fluid in RCU, and you decide to do a randomized control trial. All the patients randomized to normal saline receive normal saline, and Hartmann's receive Hartmann's, obviously. But what you do is that you make it difficult for the patient or the study personnel to know which fluid is which. So you just have packets of fluid which look exactly the same, and they have study fluid written over it. And that way nobody would know whether that particular fluid is normal saline or Hartmann's. And this could work well for all other interventions, things like medications, which would taste, smell, look exactly the same on dilution or in their ampules. And that way the patient, the health workers, or the study personnel would not be able to know as to whether the patient is receiving active intervention or the patient is receiving placebo or the control intervention. Now, for some interventions, it is not possible to blind the caregivers or the health workers. The patient might still be blinded, the outcome assessors might still be blinded, but it is not possible to blind the healthcare workers looking after the patient. So say, for example, if we were to talk about normothermia versus hypothermia after cardiac arrest trial, it is not possible for you to conceal from the healthcare workers that the patient is in hypothermia group, because they need to have cooling to maintain their body temperature, say for example in 33 to 34 degrees Celsius group, and the intervention cannot be delivered with blinded healthcare workers. The same thing is in a trial of sugar control in RCU. So let's say, for example, you randomize patients between sugar control between 4 and 6 versus 8 and 10. You need to tell the healthcare workers whether the patient is in 8 to 10 group versus 4 to 6 group. Otherwise, they will not be able to deliver the intervention. The same thing would apply to if you're looking at blood transfusion trigger. So say, for example, the patient needs to be transfused at 70 grams per DL or per liter or 100 grams per liter. You would have to tell the healthcare workers to initiate transfusion at that particular level. Otherwise, the treatment cannot be, intervention cannot be delivered. So in some cases, it is impossible to blind the healthcare workers, but even in those cases, the outcome assessor should be blinded to the treatment. So those who are doing the statistical tests, say for example of mortality, if that is the outcome, should not know that group A is the one which had lower or higher blood hemoglobin threshold, say for example, when they are analyzing results. And this is frequently done. So the data is presented as a raw data for group A versus group B. The statistical tests are done. All the results are formulated, and only then are groups unblinded to discover that group A was low hemoglobin, say for example, and group B was high hemoglobin, transfusion trigger or whatever. So sometimes it may not be possible, but must always be attempted. And obviously, if you do not have a blinded outcome assessor, it introduces a bias. It doesn't introduce you could argue that it introduces a bias if you do not have a healthcare giver who's unblinded. So say for example, if a clinician does not believe in normothermia and believes that everybody should get hypothermia after cardiac arrest, and they know that the patient is in hypothermia group, they may decide to withdraw on the patient faster, and that way there will be more mortality in hypothermia group, say for example in the normothermia group. But these are these sort of things that are looked into to make sure that the two groups have equal distribution of these therapies, that the therapies or co-interventions are equally distributed between the two groups. So there are ways to see, even in unblinded treatments, to make sure, as far as possible, it's not perfect, as far as possible, to make sure that two groups are treated equally by the healthcare givers, despite them being exposed to what group the patients are in. The next thing to assess is were the groups similar at the start of the trial. So when the patients get randomized, the baseline characteristics are noted, and frequently the patient that is the first table in a randomized controlled trial paper, the baseline characteristics of the patient. And if the patients were adequately randomized, it should normally produce well balanced groups which have no difference between their baseline characteristics. Now, it can sometimes happen that there are differences between the two groups despite what would be considered as an adequate process of randomization. And if that happens, there has to be clinical judgment about those differences, whether they are significant or not. So if you do a 10,000 patient trial with regards to blood pressure, it is very likely that because of this large size, that there will be a statistically significant difference may be found between one group having a blood pressure of systolic of 123 and the other group having a systolic blood pressure of 126. Just because of the size of the trial, sometimes or often, even small differences become statistically significant. So just before you run into any conclusions about seeing a p less than 0.05 and believing that the two groups were unbalanced with regards to that characteristic, and attention should be paid to whether that difference is clinically significant or not. So for example, in this case, with the blood pressure example, it would be insignificant clinically, though it might be statistically significant depending upon the size of the group. So this is a sort of typical table. Table 1 almost always is the characteristic of patient as baseline, and this is a table from CHEST trial, which was a trial looking at hydroxyethyl stars versus normal saline as a resuscitation fluid for ICU patients. And you can see that the patients are pretty well balanced with regards to age, gender, weight, admission source, so on and so forth. So this is a table which is first put up by the authors, and any baseline differences are pointed out. Now, usually in a big randomized controlled trial, and this was roughly a 7,000 patient trial, most of the confounders would be well taken care of, and it is unlikely that there would be any significant differences between the two groups. But sometimes significant differences between the two groups, as I mentioned earlier, can arise despite adequate randomization. Now, this is one of the examples where patients can have baseline differences despite adequate attempt of randomization. This frequently happens in patients in small trials. So this was a trial of decompressive craniectomy in diffuse traumatic brain injury, which was an Australasian trial or Australasian-led trial, and reactivity of pupil was unequally distributed between the two groups with a statistical significance. If you look at it clinically, it sort of produces a sort of a mixed and messier sort of a picture, but each characteristic on its own is in unequally distributed, which is clinically significant. So you can see that in patients who underwent decompressive craniectomy, 20 patients had none of the pupils that was reactive, whereas only 10 patients out of 80 patients, and that's a significant difference. If you look at one or the other pupil being non-reactive, then it's the other way around. So the clinical significance becomes a little bit muddled. But what the authors did was, and this is what needs to be done, is that if there is a baseline difference, then the results need to be adjusted for that variable. So we know from other studies as to if you have an unreactive pupil, what mortality disadvantage, say for example, it confers, and you can adjust the result that you get in your trial with that adjustment factor, which is known from other epidemiological studies for that effect. So in this paper, an adjustment for this unequal distribution was made to specifically cater for the difference in incidence of reactive pupils. So the next question we look at is, aside from the experimental interventions, were the groups treated equally? So this is to make sure that the only difference that remains between the two groups is the intervention or the exposure, and that they must be similar at the start, which we've already made sure, but also they are treated similarly through the study, so that the only difference that occurs between them is of the intervention, so that if there is a difference in their outcome, that can be ascribed to the intervention. If they are not treated similarly for another factor, then that would become a confounder, and that will be difficult to then ascertain as to how much of the effect is due to the intervention on their outcome. Now let's look at that with an example. So this is a table from a trial that was conducted in the United Kingdom called Caesar trial, and that was a trial looking at ECMO versus conventional ventilation for patients with ARDS. And this is sort of their table 1 or perhaps table 2, looking at various patient table 2 perhaps, because this is not baseline characteristics. But if you look at this table, the patients with ARDS, the patients who were in the ECMO group were actually more patients received steroids, and the difference, considering the size of the trial here, is clinically significant in addition to being statistically significant. And if you look at another treatment, which was treatment by low volume, low pressure ventilation strategy, there were more patients in ECMO group who had ventilation compliant with that sort of a regimen as opposed to those in the conventional group. Now at that time, it was known that low tidal volume, low pressure treatment has a mortality benefit. Unfortunately, more patients in ECMO group received that treatment. And if this trial were to find that ECMO group did better, then you would not know whether that was due to the way they were ventilated, or because of the steroids, or because of ECMO, or sort of combined result of those three, each of which individually could be non-significant. So if the two groups are treated differently, it creates a messy situation where you may not be able to pinpoint the difference in outcome to the intervention because there are multiple interventions. So that's why the two groups, apart from the intervention that is being studied, should receive the same sort of treatment, which may be by a protocol or which may be left randomly to the decision of the clinicians, and hope that the process of randomization would make sure that clinicians give random treatment to the two groups and every other treatment is equally distributed between the two groups. In this case, it was left randomly to the choice of clinicians, and it so happened that patients with ECMO received more steroids. So perhaps that should have been included in the protocol, that the patient should not be given steroids, or all patients should have been given steroids, just to make sure that steroids were not a factor. The next question is, were all patients who entered the trial properly accounted for and attributed at its conclusion? So this is to make sure that there is not a significant loss of follow-up, so that all patients who enter the trial are available for analysis at the end of the trial. Now, it is not a major problem with ICU trials. Well, at least wasn't a major problem initially, because frequently the early ICU trials dealt with ICU mortality or hospital mortality, and that was an easy factor to chase. But increasingly, ICU trials are becoming mortality or disability ascertaining trial at 6 months and 9 months, 12 months, so on and so forth, and that introduces the risk of losing patients to follow-up. Generally speaking, RCU trials, at least from Australasia, have got very good follow-up rate, and that doesn't become a problem, but that is an important factor that should be looked at. Now the question then becomes as to how much loss of follow-up is significant, and that is a very difficult question to answer. So if 10%, if there is a 10% loss of follow-up, is that significant? If 5%, 20%, 30%, how much is significant? It's a very difficult question to answer, and there are no set rules with regards to that. Generally, less than 5% or less than 10% loss of follow-up is unlikely to significantly change the results of the trial, but anything more than 10% has a potential to change the results of the trial. Certainly more than 20% or 30% loss of follow-up would probably be considered unacceptable. Again, it is not how many patients get lost, but what is the characteristic of the patient that get lost. Unfortunately, when they get lost, it cannot be determined as to what their characteristics were. One of the ways in which this problem is dealt with is to assume that all patients who were lost to follow-up had the outcome, and then analyze the data, and then assume that they did not have the outcome and analyze the data and see whether the conclusions of the trial change. And if it becomes apparent that with just patients who are lost to follow-up, they have the potential to change the results of the trial completely, then that's a significant loss. Otherwise, it may or may not be significant. So the fact that the trial results are not changed, incorporating those two extremes of outcomes, does not necessarily mean that that loss of follow-up is not significant. It just means that it has less chance of affecting the trial outcome. Let's look at that with an example. So this is the same trial that we were talking about earlier. This is ECMO versus conventional ventilation for ARDS, the same British trial or English trial. And this looked at about 90 patients in ECMO group, looked at about 90 patients in conventional ventilation group. And there were 3 patients, it doesn't sound like a big number. There were 3 patients in conventional management group that were lost to follow-up. But interestingly, if you look at the highlighted portion, if all of them were severely disabled, so the endpoint in this trial was death or disability, severe disability, and those 3 patients, depending upon whether they got the outcome or not, had a potential to change the trial. Now, this is something that we are going to look in another session. But if you look at the odds ratio, it was 0.67, with confidence intervals approaching but not crossing unity, as opposed to the odds ratio being 0.72 and the confidence intervals crossing unity if the patients who were lost to follow-up indeed had disability or had died. So here, just the loss of 3 patients can potentially reverse the result of the trial, and for that reason, it is that loss of follow-up is significant. Now, the other argument that you could make is, well, how robust is the trial anyway if it's getting affected by a loss of 3 patients? Well, that's something that we each need to answer in our own heads. But just as an example, here the loss of even 3 patients, which is perhaps 5% of that group, has made a significant difference to the results of the trial. Now, the next concept is, were the patient analyzed in the groups in which they were randomized, and that is called as an intention to treat principle. And this is sort of a interesting concept that I must say that I'm just getting my head around to. So let's say, for example, considering a pneumonia trial, patient requiring mechanical ventilation or severe community-acquired pneumonia, let's say that the patient was randomized to ceftriaxone plus azithromycin, and then and to timentin plus azithromycin. Let's say that a patient gets sick and the clinician gets frustrated, saying that I'm not happy if this patient is in control group. I want to change the treatment to tazosin plus azithromycin irrespective of whatever group the patient is in, and decides to either unblind the study or stop the study treatment and give open label tazosin plus azithromycin, what happens to this patient? That's one question. Let's deal with another question, that there is a patient who gets randomized to receive a particular intervention, but gets better or dies even before they have had a single dose of the intervention. So let's say that there is this community-acquired pneumonia patient who dies before he can be given the first dose. Should they still be analyzed with that group? Should they be taken out? Those are the sort of questions which are different. Now, the principle is that patients who either are not compliant or who do not take complete treatment, we know by by the general studies looking at their outcomes across all interventions and across all studies, that they have a poorer outcome compared to patients who are compliant and get the treatment. And that is the basis of this principle, which is called intention to treat, which means that once the patient gets randomized to a particular group, they should be analyzed in that group, irrespective of whether they get any intervention, only suboptimal dose of that intervention, or whether they get complete intervention. And we'll look into some of the examples for that. Now this is the same trial, and I apologize for going on with the same trial, but it's just a wonderful trial which gives you so many example tables. So this is the same trial of ECMO versus conventional management group. And now, rather than looking at the steroids or the treatment by low volume, low pressure ventilation strategy, I want you to concentrate on the first thing, which says treatment by ECMO. Now that says that there were only 68 patients who were in ECMO group who were treated by ECMO. So there were 22 patients in that ECMO group who ended up actually never receiving ECMO. And that is also pointed out in treatment by conventional management row, where 22 patients out of 90 in the ECMO group received conventional ventilation, whereas every patient in the conventional ventilation group received mechanical ventilation. So how should you analyze those 22 patients? Should you analyze them with conventional management patient, making it group 112 and leaving just those 68 patients who had ECMO in the ECMO group? Or should these 22 patients, just because they got randomized to ECMO group, should be analyzed with ECMO? Now this is a big question, and as I said, I've not got my head fully around to it. But as a principle, these patients should be analyzed with the ECMO patients, because that was the group that they were randomized to, and they did not get the intervention. And some people would argue that for that reason they should not be, but by principle they should be analyzed in that particular group. Now there is a concept called per protocol analysis, in which what authors do is that in addition to doing what is the intention to treat analysis, as in analyzing all patients randomized to a particular group in that group, they do what is called as a per protocol assessment. And in that, so if you were to do a per protocol analysis for this table, you would put these 22 patients in the other group and analyze 68 versus 112, just because those patients did not get the intervention and were conventionally managed. So that is called as a per protocol analysis, and it is a breach of intention to treat principle. But in intention to treat principle, they would be analyzed with patients who got ECMO. And this is another interesting example where you could argue you should do per protocol or intention to treat, and if you were to go to per protocol, how would you do that? So this was a trial published in New England Journal of Medicine, as perhaps would be obvious from the design of the table, in 2008. And it was a trial of randomizing patients between oxygen therapy versus CPAP versus BiPAP for pulmonary edema. And if you look at the highlighted portion of the table, a lot of patients from the standard oxygen treatment group got crossed over to CPAP and an IV when they started developing respiratory distress. So approximately 60 patients out of 360 received CPAP and an IV from the standard treatment group. And some patients with NIV crossed over to CPAP just because NIV was too uncomfortable for them, and some of them crossed over to just the oxygen therapy because they got better and didn't want a uncomfortable mask on their face. Now, how do you analyze those? So it would be very, very tricky to do any analysis other than just intention to treat analysis. Again, whether that's the most optimal thing to do is something that you could argue about. It will, you could argue that that will make standard oxygen treatment look better and CPAP in compared to CPAP or NIV, just because the patients got that intervention anyway. Now, you could also argue that those patients who actually crossed over may have been more sicker to start with, or the patients who continue to get oxygen therapy were perhaps not comparable sicker to CPAP or NIV. Otherwise, the rest of them should have got crossed over as well. So there are n number of conclusions that you can draw from the table. But just as a principle for us to understand, intention to treatment means that you should be analyzed in the same group that you are randomized to, irrespective of whether you do not get the therapy or only get a part of the therapy, or you cross over to the different group. Now that almost brings us to the end of the session. So we talked about internal validity. So you take a sample from a population that you want to study and hope that this sample actually represents the target population. You do intervention on that sample. There are obviously a variety of bias that can come into the way, or a random error or chance, and you make efforts to minimize, or the trialists make effort to minimize and reach a conclusion, and believe that if they have had low bias, low error by chance, that the conclusion drawn from this trial would stand true for the sample and hopefully for the population. Those are the sort of things that we'll perhaps discuss in another session. For this session, we would stop here. So the idea behind the session is to just judge the internal validity of the trial, and perhaps in the next one we'll look at the results, the power of the study, and some of the concepts. So this is an illustration to show as to what sort of different biases you can get. If the patients are not allocated in a randomized way, there is a selection bias. If they do not receive the same sort of interventions after randomization, then that's a performance bias. If they get excluded and do not get followed up, it's an exclusion bias, or which perhaps we consider a part of selection bias actually. And if their outcomes are detected by unblinded assessors, then that can cause detection bias, and all have a potential to give a result which is different to the truth by these various mechanisms. So I think we'll end the session here. Thank you.